up. In 90% of neuroblastomas, there will be calcifications in the lesion. Cross-sectional imaging is ultimately needed for mass characterization, and it is also needed for evaluation of metastatic disease and to determine the stage of the tumor. So when we talk about neuroblastoma staging, the INRGSS, which is a preoperative staging system, the International Neuroblastoma Risk Group Staging System, this was developed in 2009. And what it does is combines prognostic risk factors, including age of the patient and presence of any metastatic disease or image-defined risk factors to categorize the disease into 4 stages. The L1 stage is when there is a localized tumor. It does not involve any vital structures as defined by IDRFs. And the tumor is confined to one body compartment. So this is a localized tumor. L2 is also a local regional tumor, but there is presence of one or more image-defined risk factors, which we will be discussing shortly. M is distant metastatic disease, and MS is a subtype of distant metastatic disease in children less than 18 months of age, with the mets confined to either the skin, the liver, or the bone marrow. So let's discuss image-defined risk factors one by one. The first term is encasement. Now, encasement occurs when the tumor surrounds an adjacent structure. For a vessel that is an artery, more than 50% of the circumference of the vessel is involved. This, and for a vein, it includes a flattened vein with no visible lumen. So this is important to note that no visible lumen should be identified to call it positive for encasement. So on these MR images, this was a neuroblastoma of the neck, and you can see that there is complete encasement of the left common carotid artery, which constitutes positive encasement. Additionally, there is no lumen identified of the internal jugular vein, which is also an image-defined risk factor for encasement. Now, when there is less than 50% of circumference of the vessel that is involved by the tumor, it is referred to as contact. Now, on these images, you can see that there is a lesion in the posterior mediastinum, but the aorta circumference less than 50% is involved, and therefore this is contact with the vessel, and this is not an image-defined risk factor. Similarly, for veins, incomplete occlusion, where you can see the lumen of the vein, is called flattening, and this is also not an image-defined risk factor. The second image-defined risk factor is compression. Now, the term compression is only used when there is a thoracic tumor, and it reduces the short axis of the airway. So in this tumor on the right side, you can see that it reduces the short axis of the distal trachea and the right mainstem bronchus, and therefore this is a positive image-defined risk factor for compression. The third image-defined risk factor is infiltration. Now, infiltration is extension of the tumor into an adjacent organ where the tumor margins become ill-defined or absent, and there's loss of intervening pathway. So on these images, you can see that there is a large neuroblastoma in the retroperitoneum. Additionally, there is complete encasement of the abdominal aorta. There is complete encasement of the superior mesenteric artery as well. So these are additional image-defined risk factors for encasement. And over here, you can see that there is complete loss of intervening fat and infiltration into the porta hepatis of the liver. So this is positive for infiltration. The fourth image-defined risk factor is invasion. Now, invasion is only used for the renal pedicle, renal vascular pedicle. It includes either contact, that is less than 50% involvement of the circumference of the vessel, or encasement, which is more than 50% involvement of the renal vessels. So on these MR images, you can see that there is a large neuroblastoma, and it completely encases the right renal pedicle, and therefore it constitutes positive invasion, which is the fourth image-defined risk factor. Additionally, you can see that there is complete encasement of the abdominal aorta, and there is infiltration into the right lobe of the liver and the right kidney as well. So these are additional image-defined risk factors. When we talk about spinal canal involvement, when more than 1/3 of the spinal canal in the axial plane is invaded by the tumor, and the CSF fluid space is not visible, or the spinal cord itself shows abnormal signals on MRI, it is a positive image-defined risk factor for infiltration of the spinal canal. So over here, you can see that there is infiltration of the spinal canal by the tumor via the neural foramina, and there's complete obliteration of the CSF space. So therefore, this is positive for an image-defined risk factor, and there are additional metastatic nodules in the liver. So when we talk about metastatic disease, as I already mentioned, stage M and stage MS are the two types. MS is reserved for patients that are less than 18 months of age. So in this case, the patient was 10 months of age and the metastatic lesions were confined to either the liver, the skin, or the bone marrow. So in this case of a left sided neuroblastoma, there were multiple liver metastases in a 10-month-old. So this was an MS stage. And this was a 3-year-old child, so older than 18 months. This was also a left-sided neuroblastoma. There was thoracic lymphadenopathy and bone metastasis, but this was a stage M based on the age of the patient. So MIBG scintigraphy, it employs the use of 123 iodine meta-iodobenzyl guanidine, which is a norepinephrine analog, and that is used to evaluate the neuroendocrine tumors. So most of you got it right that MIBG is used for evaluation of neuroblastoma, and particularly to detect the skeletal metastasis, also to evaluate for a response after treatment. Now we need to be sure that 10% of the neuroblastomas can be MIBG negative. In these cases, PET-CT has an emerging role in evaluation. So moving on to the next quiz, a 3-year-old child is diagnosed with bilateral renal masses. As you can see, CT shows tumors in both kidneys with no evidence of renal vein thrombosis, lymph node involvement, or distant metastasis. So what do you think is the best staging that is described? Stage 2? Is it stage 3? Or is it stage 4? Or is it stage 5? Can someone please run the poll? Okay, 5 more seconds and then we share the results. Okay, so most of you think it is stage 2 and 29% of you think it's stage 5. The correct answer is indeed stage 5, and we'll be discussing this in the presentation as well. Okay, so when we talk about Wilms tumor or nephroblastoma, it accounts to almost 90% of pediatric renal masses, and the survival rate is almost 90%, which is excellent. Most Wilms tumors are sporadic in nature, but 10 to 20% occur in the setting of some genetic predisposition syndromes. These include the Beckwith-Wiedemann syndrome, the Vagar complex, and the Dennis-Drass syndrome. The management of Wilms tumor differs fundamentally between these two groups, the Children's Oncology Group from the US and the International Society of Pediatric Oncology from UK. And the COG guidelines, basically, they are based on upfront nephrectomy followed by chemoradiation as needed, whereas the PSYOP protocol approach is based on preoperative chemotherapy to decrease the tumor bulk and to facilitate surgical resection. So be sure of which guidelines your hospital or your oncologist follow, because that's important to know. And as we at AKU adhere to the PSYOP. So when we talk about ultrasound imaging features of Wilms tumor, the claw sign when present, it gives us a clue of the renal origin of the mass, and it is obviously defined with the acute angle of the normal renal parenchyma with the tumor, as you can see on this image. And there may be movement of the mass with the kidney during breathing. However, this may not be applicable if the renal mass has breached the renal capsule and has infiltrated other adjacent organs. Necrosis and intratumoral hemorrhage may result in a variable level of echogenicity on ultrasound, and 10% of Wilms tumor can have fine calcifications, in contrast to 90% of neuroblastomas with coarse calcification. So on ultrasound, you need to scan the ipsilateral and contralateral kidney for any synchronous lesions. So on this image, you can see that there were two separate lesions within the same kidney, and there is normal intervening parenchyma between the two. You need to carefully scan the liver and the cul-de-sac for any metastasis, and you need to check the renal vein and the IVC with both grayscale and Doppler imaging, because tumor thrombosis is often very vascular in nature and can result in a false negative if imaged only with color Doppler evaluation. So when we talk about cross-sectional imaging for Wilms tumor, again, tumor thrombosis is very essential to note because it is present in about 10% of patients with Wilms tumor and can affect the surgical management. The detection of any atrial or caval thrombosis preoperatively can help determine whether there is a need for preoperative chemotherapy in that patient and therefore affects the surgical approach. So on these images, you can see a large Wilms tumor on the left side. There is renal vein thrombosis. And on the coronal and sagittal images, you can see that the thrombosis extends into the IVC, and this should be carefully documented on our reports. Infiltration of the tumor into the adjacent structures other than the adrenal gland that would preclude complete surgical resection need to be documented as well. And signs of tumor rupture, including ascites and presence of any peritoneal tumor nodules, should be documented. Please note that intratumoral hemorrhage within the lesion or subcapsular fluid around the lesion and a small amount of ascites that is limited to the cul-de-sac does not equate to tumor rupture. And of course, a tumor volume in radiology reports for Wilms tumor is a must. And this can be easily calculated by by multiplying the maximum 3 dimensions, that is in AP, transverse, and phenocordal dimensions, and dividing the total by 2. Now, a key consideration is the presence of any ureteric involvement, which should also be carefully scrutinized and can be easily missed as well. So making use of the reformatted images for detection of ureteric involvement is crucial. Now, a bit about nephrogenic rests. What are nephrogenic rests? They are foci of residual embryonal renal tissues. These can coexist with Wilms tumor and can act as precursor lesions for Wilms tumor. There are two types, which are the perilobar and intralobar types. The perilobar types are located along the cortex of the kidney and can be homogeneously enhancing, as you can see that there are bilateral perilobar type of nephrogenic rest in this patient, and there is also a concurrent Wilms tumor on the left side. When the perilobar type of nephrogenic rests become diffuse and bilateral with enlargement of the kidneys, it is often referred to as nephroblastomatosis. The intralobar nephrogenic rests are smaller lesions. They are often located near the medullary portion of the kidneys and can have heterogeneous enhancement, and therefore sometimes to differentiate between Wilms tumor and nephrogenic rest cannot be possible alone by imaging. But some features that favor Wilms tumor is a size greater than 1.75 centimeter, a spherical morphology of the lesion, and an exophytic growth pattern. So staging of Wilms tumor, stage 1 is when the lesion is confined to the kidney, does not involve the renal sinus. Stage 2 is a localized extension of the tumor beyond the kidney or involvement of the renal sinus. Either the renal vein is involved or the ureter can also be involved. But the thing to notice is that the tumor is completely resected on surgery. Stage 3 is characterized by incomplete resection. Either there is tumor rupture, intraoperative spill, or local spread to the abdominal lymph nodes, which makes it stage 3. Stage 4 is always the presence of distant metastasis, and stage 5 is bilateral Wilms tumor, as I put up in the quiz. So stage 5 is always bilateral Wilms tumor. So when we talk about staging workup and surveillance imaging, the COG guidelines, they advocate for CT chest with the need for IV contrast to detect for disease in the chest. However, the PSYOP protocol, it advocates for CT chest without the need for IV contrast unless it is performed concurrently with a contrast enhanced abdomen and pelvis CT. CT chest should always be performed before MRI or abdominal imaging, especially for those small children who need sedation and general anesthesia, and before any surgical intervention or procedure is performed. This is to avoid obscuration of the lung parenchyma by atelectasis. Bone scans are not routine in Wilms tumor as the tumor metastasizes to the bones very late or not at all. A few words about pulmonary nodules. Imaging findings that favor pulmonary metastasis over benign lung findings, they include either the nodule is non-calcified, it is sharply marginated as in this image, and not fuzzy as these nodules over here. These were more benign appearing rather than malignant. The nodule should not be located within fissure, which favors an intrapulmonary lymph node, and a subpleural or peripheral location, especially in the lung bases where there is higher vascularity and perfusion, should always be suspicious. And a size more than 3 millimeter meeting the above mentioned criteria is always considered suspicious until proven otherwise. So this is a exam favorite question. Is it neuroblastoma or is it nephroblastoma, especially when the mass is so large and infiltrative and involves both the renal and suprarenal regions? So let's go over some of the differentiating factors and features. When there is presence of a large amount of calcification, especially if it's coarse, as I said, 90% are associated with neuroblastoma. If there is vascular encasement, there is elevation of the aorta from the retroperitoneum, and if the mass crosses the midline, it also favors neuroblastoma. If the tumor has ill-defined margins and if there is retroperitoneal lymphadenopathy, again, that favors a neuroblastoma. When the claw sign is present, it gives us a clue to the renal origin of the tumor, and that favors a Wilms tumor. When there is renal vein or IVC or atrial thrombosis, again, that favors a Wilms tumor. And if there is a tumor rupture or hemorrhage within the tumor, that also favors a Wilms tumor. Another differentiating factor is that neuroblastoma has a propensity for skeletal metastasis and nephroblastoma has a propensity for pulmonary metastasis. That brings us to quiz number 3. So a 4-year-old child presents with an abdominal mass and raised alpha-fetoprotein levels. CT shows a large liver lesion with calcifications. And what do you guys think is the most appropriate staging system for this lesion? Is it pre-treatment extent of disease? Is it pre-transplant evaluation and classification? Is it primary tumor extent classification? Or is it liver imaging reporting and data system, which is the LIDAT? Okay, so the poll is on. Five more seconds and then we stop the poll. Okay, so most of you think that it is liver imaging reporting data system, which is the LIRADS. That is not the correct answer. LIRADS is for hepatocellular carcinoma for adult patients. For pediatric patients, it is pre-treatment extent of disease, which is the PRETEXT system. And let's go over hepatoblastoma now. So we all know that it is an embryonal tumor and it's the most common primary liver malignancy in children less than 5 years of age. The serum alpha fetoprotein markers are markedly elevated in most patients, that is more than 90% of patients with hepatoblastoma. And these masses are often heterogeneous on imaging. 40% will have calcifications and 20% can be multifocal, mimicking metastatic disease. In children more than 5 years of age, hepatocellular carcinoma does become more common. So we need to keep that in mind as well. So staging is with pre-treatment extent tumor system. As I already mentioned, this was most recently revised in 2018, and it is not specific to hepatoblastoma, can be used in all pediatric liver tumor staging. So let's quickly go over the pretext system. What it does is it separates the liver into 4 sections according to the Coonad segments. The left lateral section is segments 2 above and segment 3 below. The left medial section is segment 4A above and segment 4B below. The right anterior section is segment 8 above and segment 5 below. And the right posterior section is segment 7 above and segment 6 below. Now, tumors are assigned group 1 to 4 based on the number of contiguous tumor-free liver sections. Now, for it to be contiguous, they have to be adjacent to one another, right? So pretext 1 is when the lesion is located within one section and 3 contiguous sections are tumor-free, right? Pretext 2 is when there are 2 contiguous sections of the liver which are tumor-free. Pretext 3, on the other hand, is one contiguous section of the liver which is tumor-free, and this can have a variety of possible options. Pretext 4 is simple because there is no contiguous section of the liver which is tumor-free. Now, once the pretext stage is determined, you're going to have to look for any additional annotation criteria, which we will be discussing shortly in the subsequent slides. Let's look at some examples of pretext staging. So as I mentioned, pretext 1 is when the lesion is located in one section. In this case, it was the right posterior section, and 3 adjacent contiguous sections are tumor-free. Pretext 2 is, in this case, the lesion is involving the right anterior and posterior sections, and the left medial and the left lateral sections. 2 contiguous sections are tumor-free, so it is a pretext 2 lesion. Additionally, a tumor limited to the caudate lobe also makes it pretext 2. So another tumor which is involving the center of the liver, and it is located between the left portal vein and the right hepatic vein, and it is involving the left medial section and the right anterior section, and there is only one contiguous section which is tumor free, and therefore this is pretext 3. Pretext 4, as I said, it's an easy diagnosis. The lesions are involving all sections of the liver. No section of the liver is tumor free. There can be multifocal disease in this case, or there can be a large tumor involving all sections, which is very rare. Now, what are the additional annotation criteria? The V positive disease is when there is either IVC involvement. The IVC is encased by the tumor. In this case, there's a large hepatoblastoma involving the right lobe, and there's complete encasement of the intrahepatic part of the IVC, which is a V positive disease. Additionally, if the lumen of the IVC is completely obliterated by the tumor, as you can see in these images, that is also V positive disease. And of course, tumor thrombosis, if you can see tumor thrombus within the hepatic veins or the IVC, it is also labeled as V positive disease. P positive disease similarly is involvement of the portal venous system. There can be cavernous transformation, which is also called positive P positive disease. And in this case, portal venous thrombosis or tumor thrombosis should be inferred. There can be a bland tumor thrombus that can also be labeled as P positive disease, and there could be tumor thrombosis within the portal venous system, which is also P positive disease. E positive disease is when there is extrahepatic spread of tumor. So this lesion was a diaphragmatic metastasis. You can see that there is a clear plane between the lesion and the liver, and this is a small streak of fluid also present between the lesion and the liver, and therefore makes this distinguish. You can easily distinguish the two. In this case as well, there was a diaphragmatic metastasis, and this was a lesion that was separable from the liver, and this was an E positive disease. Peritoneal tumors and nodules can also constitute E positive disease, and this should be documented as well. F positive disease is when the tumor is multifocal, right? So if there are more than one lesions, you can call it F positive disease. R positive disease means that there is tumor rupture. In this case, you can see that there is a defect in the left lobe of the liver. There is adjacent high density ascites, and this was positive for tumor rupture and hemoperitoneum. Additionally, if MRI has been performed, you can see a fluid level caused by blood breakdown products from tumor rupture. C positive disease is when there is caudate lobe involvement, right? And as I mentioned before, when a tumor is limited to the caudate lobe only, it is designated as a pretext 2 lesion. And the boundaries of the caudate lobe are easy to identify. You basically draw a line along the lateral margin of the IVC, and this line should be perpendicular to the long axis of the caudate lobe. So this makes up your medial border of your caudate lobe. Similarly, on the coronal images, a line is drawn along the lateral margin of the IVC, right? And this becomes your medial border of your caudate lobe. N positive disease is obviously when there is lymphadenopathy with a short axis diameter of more than 1 centimeter. And for portocaval lymph nodes, the short axis of diameter should be more than 1.5 centimeter. Spherical morphology and loss of fatty hilum are additional features. And on these images, you can see that the tumor is located within the caudate lobe, and there are additional retroperitoneal lymph nodes. So this was N positive disease. M positive disease is distant metastatic disease, and lungs are again a frequent site, 17% at the diagnosis. And again, CT chest should be performed before any abdominal imaging to avoid obscuration by atelectasis. And in patients with persistent atelectasis, prone imaging can be employed for better detection of any pulmonary nodules. Now, some points to note are that pretext group and pretext annotation factors should be reassessed during each imaging time point after chemoradiation therapy. And a pretext 4 lesion and any presence of any positive annotation factors, it places the patient into a high risk category for management purposes, right? And after diagnosis and chemotherapy, these factors are referred to as post-text factors, that is post-treatment extent of disease. So the take-home points from my talk are CT chest should always be performed before abdominal imaging, especially for children who need sedation or anesthesia, and especially before any surgical intervention or procedure to avoid obscuration of lung by atelectasis. For Wilms tumor, a bilateral disease or tumor thrombus in the IVC or higher can substantially affect the surgical management and needs to be documented. Inclusion of tumor volume in radiology reports is recommended, especially for Wilms tumor. And interpreting radiologists should always recognize and adopt the unique staging systems such as image-defined risk factors for neuroblastoma and pretext system for liver tumors like hepatoblastoma. So these are the references for this presentation. That brings me to the end of my talk. I hope this was a useful session for you all and that you were able to incorporate some of these pointers in your daily practice. Thank you very much.
Thank you so much, Dr. Kamal, for this wonderful review of differentials on pediatric abdominal oncology with fantastic descriptions of staging and imaging guidelines. I now request Dr. Danish to proceed with his talk. Over to you, Dr. Danish.
Thank you very much, Shariar. My name is Danish, and I will be talking about pediatric abdominal oncological emergencies. Before proceeding to my presentation, I would like to thank the Committee of Pediatric Radiology Basic Courses, and specifically Dr. Kiran Hilal, for giving me this opportunity to talk about oncological imaging emergencies in pediatric abdomen. So I have no financial disclosure or conflict of interest in my presented material. Pediatric cancers differ from adult malignancies in their type, prevalence, and location, and therefore knowledge of tumor behavior.
Danish, can you just share your screen, please? You haven't shared your screen.
Okay, so sorry about that. Let me share my screen first.
Yes, now we can see your disclosure slide. Thank you.
Excellent. So let's start from the beginning. So my name is Danish, and I will be talking about pediatric abdominal oncological emergencies. And I don't have any disclosures. And regarding pediatric abdominal oncological imaging and emergencies, pediatric cancers differ from adult malignancies in their type, prevalence, and location, and therefore knowledge of tumor behavior is crucial in predicting acute complications. Conventional radiography can be helpful in suspecting bowel perforation, obstruction, airway obstruction from mediastinal masses. However, ultrasound and CT are frequently more informative. MRI imaging is excellent for characterizing and staging primary malignancies. However, it has less of a role in the emergency scenario apart from neurological emergencies. So many emergency physicians have little experience with pediatric oncological emergencies. They may feel less equipped to understand the extent of the underlying medical and mechanical issue in such complex scenarios. As a radiologist, you are privileged to understand the complication in depth and help your fellow clinician. So as Dr. Khandwala has already explained all different type of important pediatric tumors, abdominal tumors, I will more focus on their complications. And again, you saw multiple slides of tumor rupture, which is a very important complication, which we will discuss in our slides. So there are different complications which you may experience or see in your reporting or in your radiological experience. They can be compartment syndrome, bowel obstruction, intestinal graft versus host disease, acute pancreatitis, and so on. So abdominal compartment syndrome is potentially life-threatening complication carrying a mortality rate of up to 60%. The underlying mechanism is where an increase in abdominal compartment volume exceeds the relative expansion capacity of the abdominal wall. This leads to inadequate end organ perfusion, organ dysfunction, and organ failure. Surgical referral is essential, and emergency decompressive laparotomy may be required. Possible etiologies include any cause of rapid increase in abdominal contents, such as bilateral Wilms tumor, rapidly proliferating acute lymphoblastic leukemia infiltrates, giant ovarian masses, or even ascites. Sometimes splinting of the diaphragm and pulmonary atelectasis are other findings which you have to keep in account, that they can give you an idea of abdominal compartment syndrome. So this here is an image of a tumor, which is a neuroblastoma causing significant mass effect over the abdominal structures, specifically the left kidney, which is displaced laterally. And again, on the coronal image, you can see the extent of the tumor inferiorly into the lower abdomen, and as well causing splinting of the diaphragm. This is an example of a newborn baby diagnosed with high-risk neuroblastoma at birth. presented with abdominal distension, vomiting, and discomfort. The first image is a coronal T2 weighted sequence, and here you can see a heterogeneous mass in suprarenal location. So this is the left kidney, and this mass is located above the left kidney. And you can also appreciate the enlargement of the liver, which is studded with multiple metastases, and there is compression of the IVC. Again, you can see that there is mass effect over the diaphragm, and the thoracic cavity itself appear quite small. The second ultrasound image is of the left kidney, and you can see the left kidney is compressed and displaced downward, and the suprarenal region is all occupied by this mass. And on the third image, you can see the image of the liver with multiple metastases. Some of them are showing necrosis. Small bowel intussusception and obstruction results from diffuse large B-cell lymphoma in 5-year-old patient. So obstruction can occur due to many causes. This is the case with a diffuse large B-cell lymphoma. On this radiograph, you can see multiple air fluid levels, giving you an idea that there is ongoing obstruction, and this is the lead point or cause of the obstruction. You can see a donut sign with multiple lymph nodes, which are the lead point for this intussusception. So whenever you see something like that, you have to mention about the ongoing oncological process, but you have to pick up the phone, call your clinician, and talk about the critical finding that you have observed. Another example of a 6-year-old with small bowel Burkitt lymphoma. So we know that this patient has the underlying disease, but what is going on other than that is bowel perforation. The first radiograph is showing distension of the stomach and dilatation of these small bowels. And you can observe these mottling lucencies in the mid and lower abdomen. Here on the CT scan coronal view in lung window, you can see again mottling lucency, which is the small bowel Burkitt lymphoma, but you can also appreciate pneumoperitoneum, which is a critical finding, and you have to inform your clinician. Graft versus host disease is a very serious complication that occurs when donor T cell lymphocytes reacts with the host tissue, such as those in skin, liver, and GI tract. Acute GVHD is usually diagnosed on clinical basis, but it is often difficult to differentiate from thrombotic microangiopathy or cytomegalovirus virus infection. It occurs in the first 100 days after transplant. So that is very important, first 100 days. Patient usually presents with a pruritic maculopapular rash, hepatitis, and GI abnormalities such as crampy abdominal pain, nausea, vomiting, or profuse diarrhea. Pathologically, acute GVHD is characterized by selective epithelial damage in target organs. In intestinal cases, the destruction of intestinal crypt cells, especially at the base of the crypts, results in patchy or diffuse mucosal ulceration. But be careful, you have to understand the other differential diagnosis, which can be neutropenic colitis, infectious enterocolitis, including pseudomembranous colitis, and viral infection and tumor infiltration. So you have to be careful and keep your differentials in mind. This is an example of GVHD, and you can see there is diffuse bowel wall thickening in multiple small bowel loops, and there is abnormal mucosal enhancement, as well as there is surrounding edema and free fluid. Again, you can not only diagnose graft versus host disease on imaging, you have to have a clinical picture in mind. Another example of GVHD in a 9-year-old with acute lymphoblastic leukemia who developed severe vomiting 50 days after transplant. The first image is showing diffuse small bowel loop thickening, and on the second image you can see extensive pneumatosis. So whenever we see pneumatosis, we are confused how significant this finding is. So pneumatosis intestinal is occasionally associated with GVHD, and in recent studies 10% of the children develop pneumatosis in median age of 90 days post-transplant. Most of them were successfully treated medically. Surprisingly, pneumatosis indicates a relatively benign form of GVHD. In contrast, if you see other features, as I mentioned before, such as bowel thickening, free fluid, peri-intestinal fat stranding, these are more serious complication and that can lead to perforation and other complication. So whenever you have nematosis, you have to inform the clinician, but usually the course of treatment is medical and conservative. But if you see other findings, it is then it is more likely that it will go to more serious complications. Acute pancreatitis caused by aspergillus in a 4-year-old patient with acute lymphoblastic leukemia. This is a sonographic image of the pancreas. You can see there is abnormal edema and distension of the pancreas itself. And on the CT scan image, you can see that the pancreas itself appears significantly edematous with peripancreatic inflammatory changes and free fluid. An example of tumor rupture in a 2-year-old with Wilms tumor. The first axial image of the CT scan, you can see that the tumor wall is deficit along the anterior lateral aspect of the tumor. And on the second coronal image, you can see that the tumor is infiltrating the mid and lower portion of the tumor, of the kidney, and the lower part is deficit. So the capsule of the lesion of the kidney is deficit below, and you can see extensive hemorrhage at the in the pelvis. This is an example of a 3-year-old girl with stage 4 neuroblastoma and acute intratumoral bleed. So the first image is showing extensive tumor, which is displacing the organs at the periphery, and you can also observe hydronephrosis in the left kidney. But what else you can see is areas of intratumoral bleed. So you have to be careful and you have to correlate your finding clinically and see what are the hemoglobin levels. The second image is post-embolization, and this image was taken approximately 1 month after the treatment. You can see a large hematoma within the lesion. However, there is no active extravasation, and you can also see there is improvement in the hydronephrosis. This is an example of a 13-year-old with a left-sided Wilms tumor and pulmonary embolism. So I will start with the coronal CT image. You can see there is a lesion which is involving the mid and upper pole of the left kidney and causing extensive mass effect over the vessels. And on the second image, you can see that the lesion itself is extending and invading into the renal vein. And on the first image, you can see that there is pulmonary embolism and both of the pulmonary arteries are filling with this filling defect. So it is the time to pick up the phone and call your clinician. Acute genitourinary complications in children with malignancies may be caused by prerenal cause like septic shock, renal injury like tumor lysis, chemotherapeutic agents such as methotrexate or cisplatin, or it can be postrenal obstruction. Here you can see hydronephrosis in the left kidney. And what is the cause of the hydronephrosis? On the CT scan, you can see massive peritoneal carcinosis with multiple calcification throughout the peritoneum. And you can see the left kidney itself is hydronephrotic, and as well as there you can also appreciate hydroureter. Obstructive uropathy in a 12-year-old patient caused by desmoid tumor associated with Gardner syndrome. In the first image, you can see a horseshoe-shaped kidney with hydronephrosis. In the second image, you can again appreciate the horseshoe kidney with hydronephrosis, but you can also appreciate hydroureter below. And on the third image, you can see that there is hydroureter, as well as there is tumor infiltration into the ureter, as well as sigmoid. Here you can also appreciate that there is a cystic focus below the ureter, which is a urinoma. And if you go back to your first images, the two images, you will see that there is extensive ascites. So if you correlate all these findings, it means that this urinoma has ruptured and there is urine or urine-filled ascites throughout the abdomen. Hemorrhagic cystitis caused by cyclophosphamide in a 2-year-old with germ cell tumor, the first sonographic image is showing a filling defect within the urinary bladder, and you can observe that there is extensive thickening of the urinary bladder. The second axial image of the MR, you can see that there is irregular thickening of the urinary bladder, and that there is perivesicular edema. And on the third post-contrast image, as you can see that there is enhancement of the wall of the urinary bladder, and again you can appreciate the thickening of the urinary bladder. This is an example of a 5-year-old boy presented with jaundice from biliary rhabdomyosarcoma. The first image is showing extensive tumor which is infiltrating into the biliary system. And on the second sonographic image, you can see abnormal vascularity within this lesion. The third image is a axial T2 weighted sequence, which is showing tumor within the biliary system, and there is intrahepatic dilatation. Here, you have to be careful that intrahepatic dilatation itself is not a complication or a concerning feature, but you have to correlate it with your clinical picture. You have to think about intrahepatic dilatation with stricture formation or periductal enhancement or cholangitic abscesses. So if you have a clinical picture of cholangitis or cholangitic abscesses, then it is the right time to call your physician and seek help. So it's time to run the poll now. And my first question to you guys is, what is the next step to confirm the intestinal graft versus host disease? And so I will give you approximately 10 seconds to answer this question. Your options are endoscopy and biopsy, or exclusion of other causes. Excellent. So the answer to this question is endoscopy and biopsy. So yes, you have to exclude other causes, but the final diagnosis is always endoscopy and biopsy. So whenever you think you are in a dilemma to give a right answer, ask your clinician to do a scope and take biopsy. So my next question is, what is the most common complication of pancreatitis? Can you guys see my poll?
I think, Danish, you just go back and then run the, yeah, that's now we can
Yes.
see that.
Now we can see the poll. And your option are pancreatic necrosis and pancreatic pseudocyst. So the question is, what is the most common complication of pancreatitis? Okay, so the right answer is pancreatic pseudocyst. So pancreatic pseudocyst is the most common complication of pancreatitis. Now I will go towards a bonus question, which is slightly unrelated to abdominal imaging, but you have to find the critical finding. So this is a CT scan of the neck showing images in the lung window as well as soft tissue window, and you can see a large mass involving the thyroid bilaterally, which abnormal enhancement, and there is narrowing of the airway. So I will run the poll. I will ask Sharia to please run the poll. And my question is, what is the most important finding you will inform your referring physician? So your options are large thyroid mass or tracheal compression. And excellent. We have 98% response with the right answer that tracheal compression is the most important finding that you have to tell your clinician that yes, there is a airway compromise and they have to take the patient and take care of that. And these are my references for this presentation. And thank you very much for your time. If you have any questions after the question and answer session, please do reach out to me.
The topic of today's talk is the pediatric non-traumatic emergencies related to GU. And so in this regard, it is divided into two main sections. The first is the male genitourinary emergencies, in which we will be more confined towards a patient with a scrotal pain. And the second would be the female GU emergencies, in which we will be more focused in a female patient with pelvic pain. In the male side, the most common things which are going to present as scrotal pain are the testicular torsion, torsion of the appendix testes, epididymitis, incarcerated inguinal hernia, and acute idiopathic scrotal edema. One important thing which I want you to note is that the most common cause of scrotal pain is not the testicular torsion, rather it's 1/3 of the all patients, whereas the torsion of appendix testes is most common cause, and it's like about 2/3 of the patients. So you have to keep this in mind when you are dealing with any patient who presents to you with acute scrotal pain. Now, regarding a basic anatomy of the testis, it is covered with the tunica vaginalis, which is sort of attaching it to not allowing it to rotate freely. And then there are vessels which are approaching it through the inguinal canal. And the testicular torsion is the twisting of these supply vessels and resulting in the occlusion of the supply to these testes. So again, there are two main types. The first one is the extravaginal type, and the other is the intravaginal. For the extravaginal, it occurs normally in the neonates, and most of them occur in intrauterine life. So it's less likely or less common that you are going to see this patient with extravaginal testicular torsion. Whereas for the intravaginal, it's the most common one, and it is associated with the bell clapper deformity, which we will see in a moment. And in this case, the intravaginal torsion, the twisting of the vessels occurs within the tunica vaginalis, the covering, whereas in the extravaginal, the tunica also twists along with the vessels. So this is the extravaginal, which is normally seen in neonates. And this is the one which we will be seeing more commonly in our clinical practices. So this is an image of a bell clapper. So if you see this one, so you can have an idea. This means like a bell clapper, the testis is not attached to any side and is just hanging around. And the reason for this is that normally what happens is like the tunica vaginalis inserts and fixes the testis in its location, whereas sometimes it either inserts abnormally high. So this results in a hanging sort of testes within the scrotum. So this results in acute testicular torsion. So in the acute testicular torsion settings, we have like three different types. One is the complete, then is the partial, and then is the intermittent. So starting with the complete one, now we will move to partial and intermittent. And the important thing which I want you all to note is that the time is the sort of the residual testis which you are going to save. So if you diagnose and treat the patient within the 6 hours, so it's going to be like 100% salvage of the testes. Whereas if the time passes and gets between something like 6 to 12 hours, it becomes just like 70% of chance. And then if it gets less than, it passes more than 24 hours, then it's less than 10% chance that you are going to save the testes. So in complete testicular torsion, the first thing which you would be noting is that on a grayscale, obviously if it's less than 6 hours and the patient has been presenting to you, so the only finding which you can appreciate is an abnormal alignment of the testes. Like if you compare this with this one, so you can see that this is showing a different angulation as compared to the skin of the scrotum. So this could be the first finding, and this is because of the twisting of the vessels, which is resulting in some malalignment of the testes within the scrotum. But the mainstay of the imaging is going to be the color Doppler, and make sure like you have an appropriate Doppler settings, and preferably in a power Doppler setup, in which you can measure the amplitude of the blood flow. So this means like in the color Doppler setting with a proper sensitivity declared, you must have an image in which you are going to evaluate both testes side by side. Like evaluating one and then another is not a good approach. Rather, you have to make sure like you place your probe in such a position that you are going to see both testes side by side, as in this image. Now, in this image, you can see that on the this side, there is no significant flow noted, whereas on this side, normal flow pattern is seen. So if you see on the symptomatic side, absent flow or a severely decreased flow, then you have a sensitivity and specificity of 100% and 90%. And in the late stages, what you can see here is that there is now change in the architecture, and now the testis is going to be enlarging in size. And you can also see on the Doppler is still diminished, and the same architecture changes occur, which is resulting in the breakdown of the testicular parenchyma and due to the ischemic changes. So this, and then there is also complex hydrocele, which is more likely due to some bleeding going around the testicle. Okay, so next thing which we need to discuss is the partial testicular torsion. And that partial testicular torsion, it occurs when the twist of the spermatic cord is less than 450 degrees. So it's like a 1.5 twist, or less than 1.5 twist. In that case, you have some flow going on into the testes, and but obviously on the grayscale is less likely to show any significant findings. But on the Doppler imaging, when compared side by side, you will see reduced flow on the symptomatic side. It would not be an absent flow, but obviously it's going to be a relatively reduced flow. And this evaluation is only possible if you are going to evaluate testes side by side. And one other thing which you can see, but if you see still twisting of the vessels or the spermatic cord with whirlpool sign of like blood flow going in this way, so that suggests that this is partial testicular torsion. And then we come to the last entity of the testicular torsion, which is intermittent testicular torsion. And this is a sort of a confusing case normally, because there is an acute onset of pain in the child, and then when normally the patient comes to the clinician. So by that time, the torsed testes becomes detorsed, and then the blood supply is going back to normal, or even more than the normal side. So this is more important from the history point of view. But when you do a Doppler, or the grayscale is not going to show much of anything, but only one thing which can be seen is that there would be a swollen epididymis on the side of the partial torsion. And then on the Doppler study, there would be some interesting finding, and that is that the symptomatic side is going to show relatively increased flow, or rather than the normal side. And then the epididymis is like swollen, but it appears like an epididymitis. But you have to make sure like that there is no history of any fever, and the epididymitis is a less likely finding in a pediatric population in which we are more likely to see these cases, the testicular torsion case. And in the flow patterns, you can see that there is low resistance flow on the affected side, or which was the partially tossed testis. So to make sure you have this diagnosis in mind, that it can twist and detwist. So the patient, when presenting to your clinic, can be having even increased flow to the testicular side, and that should be mentioned because that is something important, and that can result in complete occlusion afterwards. Now then we move to the next topic, which is the torsion of the appendix testis. And as we have just seen that the torsion of the appendix testis is more or the most common cause of the acute scrotal pain. So in this case, what you are going to see is that there are multiple appendages which are hanging out of the testes, and you can see that, but the two most important one are the appendix testis and the appendix epididymis. So we have like appendix testis 92% of the time, and appendix epididymis on the 7% time. So, but the important thing is that these both are towards the other side where the epididymis is. So it's more likely that you are going to see these lesion towards the medial side of the epididymis. So that is going to help you differentiate between this. So in this case, if you see this structure, so this is sort of a Mickey Mouse sign. So this is the appendix testis, and the important thing is that in this case, it is more like a conservative treatment rather than a surgical treatment, and it resolves on its own. There is no need of surgery in this patient, whereas in the obviously in the testicular torsion patient, it is an urgent emergency case. So in this case, another similar thing where you can see the testes, you can see the epididymis, which is also secondary inflamed because by the torsion of the appendix testes, there is secondary inflammatory changes like epididymal enlargement, hyperemia, and reactive hydrocele, and thickening of the tunica albuginea and scrotal wall as well. So it can show you an appearance of epididymitis, but to make sure that this is an additional structure which you are seeing, and this is the torsion of appendix testes. Now we move to the next thing, which is the epididymitis, and this is relatively rare in a pediatric population. And so importantly, it's like in pubertal patients, you can see this, but in prepubertal, it's less likely unless there is some associated GU tract abnormality, such as like the patient is having reflux or something like that, which is inducing UTIs again and again, and that can lead to epididymitis. But for the epididymitis, you can see that there would be a history of the scrotal wall thickening, reactive hydrocele, and significant hyperemia of the epididymis, and then you have a typical history of fever and all those things which you are less likely to find in other the pathologies we have discussed so far. So this is again a picture of the diffusion and focal or diffuse enlargement of epididymis due to epididymitis, and all these findings are seen. Then we are seeing the last of this testicular problems or the scrotal problems, and that is going to be the acute idiopathic scrotal edema. So what happens is like there is an increased like water fountain sort of appearance of the increased vascular flow. So if you see, there is diffuse thickening of the scrotal wall, there is extensive edema, and then there is a pattern of the blood flow which is extending and showing a water fountain type like appearance. And this is also again a self-limiting condition, and you don't need to do much of a intervention. This will resolve on its own. So it's just like an hyperemia of the scrotal wall. Now moving to the next thing, which you can see in this inguinal region. The other pathologies include the incarcerated inguinal hernia. It's more likely to occur in a premature patient because of the patent processus vaginalis, and that leads to herniation of bowel loops, and that can lead to further incarceration, and that can lead to obstruction and other pathologies. So it is more common going to occur on the right inguinal region than the left, and because the right inguinal canal closes after the left, so you are more likely to see the right inguinal hernias in a pediatric population. So moving to the next one, it's the encysted spermatic cord hydrocele. So this can also present with a swelling in the inguinal region. So once the testis is descended into the scrotal sac, the processus vaginal closes itself. But sometimes you can have a different variety of like persistent processus areas, like a cyst, which is extending all the way in any place within the inguinal canal or the scrotal sac. So this is known as the encysted spermatic cord hydrocele. And on an image, you can see, you would be able to see one cystic area, which is involving the inguinal canal and can extend all the way from the scrotum up to the deep inguinal ring region. So you can use the ultrasound, as it's going to show you more like a cystic area, and you can distinguish it from hernia, lymphadenopathy, or some other tumors. And definitely no internal vascularity could be observed. However, peripheral vascularity is going to be sometimes seen, and then it's separate from the testis and epididymis. So now we are going to move to the second section, and that's the female GU emergencies. And we have a variety of different pathologies which can present with acute abdominal pain in a pediatric female patient, and the number one being the ovarian torsion. Then there is a fallopian tube torsion, then hemorrhagic cyst, adnexal dermoid, and hematometrocolpos. And we are going to see briefly about each of these pathologies. The ovarian torsion could be like partial or complete, and rotation of the ovary, and which twists along its vascular pedicle. And in this case, there is an acute pelvic pain and associated with nausea, vomiting. The patient normally presents with vomiting, and it is confused with the normal UTI or something similar to that. But you have to make sure like this pain is pretty acute and very much severe for the patient to bear out. And this is the findings are a bit different, obviously. The first thing is that the ovary enlarges and the cysts are seen more arranged in the periphery. So it's like multiple cysts, peripherally located cysts. And then what happens is like it's more like because of the twisting of the pedicle, the venous drainage of the ovary compromises first. So it starts to like accumulate fluid within the ovary, and that also results in the parenchymal or intrastromal hemorrhages, and you can see a cystic area within the ovary as well. So that's like an oozing of the blood into the parenchyma of the ovary. And so in this case, you can see that there is a large ovary, you can see a fluid around it. And the second thing is like because the ovary is going to be twisting, so it comes towards the midline because the pedicle gets short and it gets twisted. So as there was some abnormal alignment, you saw in the testicular torsion, this also comes in the midline, and it's more like in the cul-de-sac posterior to the uterus. And then the color Doppler is not reliable in this ovarian torsion, and you have to rely on the other findings. And this is very important because first thing is that it's going to be a deep-seated structure. So sometimes you are not able to get a good spectral imaging, and you cannot get a good Doppler sometimes. But still, because in the first part of the torsion, the venous occlusion occurs. So in that case, you can see some arterial supply going on, but obviously it's going to proceed and it can result in necrosis of the ovary. So, for example, this is like showing no significant vascularity within the parenchyma, and this is showing a torsed ovary with the vascularity in the periphery. So these are some findings which you need to keep in mind. And then again, these important things are that it's going to be in the midline, more along the posterior aspect of the uterus, and the vascularity or color Doppler is not a reliable way to judge for the ovarian torsion. Rather, history and the grayscale imaging findings are more reliable in this case. So the next cause which the patient can present is an hemorrhagic ovarian cyst, and you can see in this case the right ovary is showing a hypoechoic area with internal lacy pattern and septations and internal debris with echoes. So this is a hemorrhagic cyst within the right ovary, and you can and this patient is going to present with an acute pain as well, but you can clearly differentiate between this finding of hemorrhagic cyst versus the ovarian torsion, which you can see in this image more clearly. And yeah, this is another one which is showing perifocal vascularity and the internal echoes or hypoechoic area within the ovary. And then another thing which the patient presents with is the fallopian tube torsion. And we have a paratubal cyst normally associated with this, and this results like in a torsion of the fallopian tube itself. And now, and this is and the right tube is torsed more commonly than the left one. And what you see on an ultrasound is like a large cystic structure which is sort of displacing the uterine body anteriorly, and this is very important because you are going to see this cyst in the cul-de-sac region. So this can be confused with a simple ovarian cyst. And another finding, edematous fallopian tube. You can see a rounded structure here, which is like showing the edematous fallopian tube in the adnexal region. So you can see ovary separately from this rounded structure. Another one which is going to be the important thing which is going to present with pain is the adnexal dermoid, and this is the most common ovarian neoplasm in the children. And almost all are benign. With most of the patients, when they first present, that is because of either of the torsion of the ovary due to the adnexal dermoid, and or in the hemorrhage intratumoral hemorrhage, or the so you can see obviously the typical findings, which is a complex cystic mass, which is going to show an hyperechoic area representing the fat, and calcifications as well as in form of a punctate areas. Then we have the another pathology which can present with acute abdominal pain or a pelvic mass, and that is going to be the hematocolpos, in which there is like hemorrhagic material filling and distending the vagina and or uterus depending on the severity of the problem. And normally we have two peaks. One is in the neonatal region, a neonatal age, and that's like when the baby is born, and because of the maternal hormone influences, this is all the collection going on inside the uterus. And then for some time, for a few years, there is less incidence, and then when the patient it reaches the age of menarche, and then there is going to be the second peak because of the blood products being collected within the vagina or the uterus. So you have to keep this in mind. And now this concludes our talk on the acute emergencies, and a few summary is that torsion of the testicular appendages is more common than acute testicular and epididymitis. This is the first thing. Then partial and intermittent testicular torsion can be a challenging diagnosis, but this patient will present with a typical history. And then look for edematous spermatic cord, pseudomass, and Whirlpool sign on color Doppler for partial and intermittent testicular torsions. And obviously, the asymmetric increased flow in the symptomatic side indicates it's an intermittent testicular torsion, and this is important thing. Like if there is reduced flow, then it's going to be the torsion, and if it's going to be the increased flow on the symptomatic side, it's going to be detorsion or the intermittent torsions. And for the female patients, ovarian enlargement is the most common sonographic appearance of ovarian torsion. And the things to remember are midline position of the ovary, like you see it along the posterior aspect of the uterus in the midline area. Then you have peripherally arranged follicles, diminished flow. But remember that in ovarian torsion, Doppler has a less low role, and you have to rely more on a grayscale imaging, or like seeing the other findings. And And then we, in the fallopian tube torsion, if you see a midline cystic structure in the cul-de-sac, do consider the diagnosis of fallopian tube torsion in that case. And then hemorrhagic cyst can mimic like an ovarian torsion. That's very important. But you can now appreciate that it was a bit different in appearance. And hematocolpos can present an acute pelvic pain as well. So you have to remember that in mind as well. So thanks for listening to the talk. And if you have any questions, you can write down.
Okay, so with that, this concludes our session for the 3 talks by our 3 guest speakers today. So now we're going on to the question and answer session. We are going to start off with, we have a lot of few questions, but we're going to start off with a few questions that are directed towards Dr. Komal. So Dr. Komal, the first question that have been asked by the audience is that how to differentiate between tumor thrombus and a bland thrombus, asked by Abbas Irfan.
Shariag, you can unshare your screen.
So my screen is unshared.
I think
Mina's screen is
sharing.
being shared. Mina, please unshare your screen.
Okay, so this is an interesting question, how to differentiate bland thrombus from tumor thrombus. It sometimes becomes very confusing, I agree. But a few pointers. I think tumor thrombus, typically it enhances with contrast, just like the primary tumor itself, and it is often contiguous with the primary tumor, and therefore it expands the lumen of the vein. Whereas a bland thrombus does not enhance, appears smoother, and it conforms to the vessel lumen. And additionally, if MRI has been done, diffusion weighted imaging can show that the tumor thrombus will show diffusion restriction, and even color Doppler imaging can be used in aiding this differentiation, because a tumor thrombus will be vascular in comparison to bland thrombus, which will be avascular.
Right. So the next question is directed towards Dr. Danish. So what is the usual extent of bowel involvement in intestinal graft versus host reaction, asked by Nida Rauf?
It's a very nice question, and as I mentioned before, that pathologically acute graft versus host disease is characterized by selective epithelial damage in the target organs. So extent of disease can start from pneumatosis, then bowel wall thickening, leading to marked mucosal enhancement, peribowel edema, fat stranding, free fluid, and eventually perforation. And it can involve both small and large bowel.
Right. So the next question is directed towards Dr. Amin, that sometimes we get confused with scrotal edema, where fat is echogenic and Fournier's gangrene is also another differential. So should we keep a high threshold for Fournier's gangrene? This has been asked by Dr. Aman.
Assalamu alaikum. I think that for the first thing which you are going to see differently, especially in the acute scrotal edema and the patient with Fournier gangrene, is the age. I think it's less likely to have a simple scrotal edema in an old age patient. Secondly, I think like there is also some other history going on, such as necrosis, which you can see more significantly on the skin. And then secondly, also the air locules, which can sort of block the penetration of the ultrasound. So that can also give you an idea, like if it's like a air within that area. So I think like you can keep that, but I think like normally the presentation is going to be altogether different in those cases. So I think like when it's a pediatric age group patient, so then I think like more likely you are going to deal with the simple scrotal edema. Whereas if it's the patient is like more than 50 years of age, diabetic and all those things, then I think, you can consider that as well.
Right. So the next question directed towards Dr. Komal from an anonymous audience, that any imaging features to distinguish Wilms tumor from other renal tumors in the same age group?
I think it's very difficult by just imaging alone, but certain differentials need to be kept in mind, particularly mesoblastic nephroma. These are more common in infants less than 3 months of age. So age plays a critical factor in your differential diagnosis. In children older than 3 months, consider Wilms tumor. In children less than 3 months of age, consider mesoblastic nephroma, which is more common in these patients rather than Wilms tumor. Other differentials also include a rhabdoid tumor or sarcomatous lesions of the kidney. But again, imaging does not help in the diagnosis. A few pointers are that in sarcomatous lesions, there may be a metastatic disease, which is more common, particularly bone metastasis. And in rhabdoid tumors, there may be other malignancies as well. Intracranial tumors can be present. And in cases of bilateral renal lesions, particularly where there is lymphadenopathy, you should always consider lymphoma in the differential diagnosis as well. But ultimately, a biopsy is definitely the answer.
Right, sir. Thank you for that comprehensive review. So the next question for Dr. Danish is how to differentiate on imaging whether there is a graft versus host disease or other infection as the patient is already immunocompromised and prone to other infections. This is asked by Wajiha Rafiq.
Very nice question, but unfortunately, it's difficult to differentiate different other causes of infection with graft versus host disease, because even in graft versus host disease, the patient is immunocompromised. So the best way to diagnose is endoscopy and biopsy. So tissue sample is the answer to this question. Back to you, Shahryar.
Right, sir. So the next question has been directed towards Dr. Amin. This has been asked by a few audience multiple times. So the question is that how to differentiate between a tubal torsion from a tubo-ovarian abscess or a simple ovarian cyst on ultrasound?
Okay, so I think like in this case, like for like there are two different parts of about the tubo-ovarian abscess. Like the content is more likely to be a more turbid in the case of an abscess scenario, and also the again the history is also going to help you with the fever and all the UTI symptoms going on. Whereas if we discuss it with the simple ovarian cyst, I think like it's more like the location of the cyst which can help you differentiate, especially like if it's behind the uterus. It's less likely that the ovary is cyst is going to come and take that position. Whereas the tubo-ovarian, as it twists like the fallopian tube torsion, so it comes behind the uterus. So it's more like a midline position, which is going to help you more. And especially the acute pain, it's less likely that the simple ovarian cyst is going to present with pain in a pediatric patient or a young age female. Whereas the torsion is going to present with an acute pain of the patient. So make sure like you don't just simply label it as simple ovarian cyst, because that will just put it in 6 weeks follow-up. Rather just make sure like if it's a cyst behind the uterus, so you have a high suspicion for the torsion of the tube.
Right. So the next question directed towards Dr. Komal. Kindly tell differentiating points between neuroblastoma and nephroblastoma.
Okay, for this question, I think I'll just share my slides so it becomes easier for you guys to maybe take a screenshot. These are the differentiating features. Calcification, as I mentioned, more common in neuroblastoma, less common in Wilms tumor, encasement of the vascular structures, and elevation of the aorta from the retroperitoneum, more common with neuroblastoma, whereas displacement of the vessels is more common in Wilms tumor with vascular thrombosis. A younger age group favors neuroblastoma, but a slightly older age group favors Wilms tumor. The poorly marginated lesions favor neuroblastoma, but Wilms tumor are well circumscribed. Elevation of the aorta, we already talked about. Claw sign favors a Wilms tumor. Vascular thrombosis, we already talked about. Crossing of the midline is more seen in neuroblastoma, rarely seen in Wilms tumor. Bony metastasis more common in neuroblastoma, but pulmonary metastasis common in Wilms tumor. Higher incidence of hemorrhage in Wilms tumor, and a higher incidence of lymphadenopathy in neuroblastoma.
Right, sir. So the next question directed towards Dr. Danish. Is there any role of IVP in assessing urinary tract obstruction if CT is inconclusive in pediatric patients? This is again asked by Nida Rauf.
Very nice question, Nida. But in here we are not doing IVP that frequently, or we are not even doing it. So I think the last time I did IVP was probably 5 years or 8 years ago. So if you have a question that you are concerned about obstruction, what I will say is do a delay image in your CT scan. So if you will include a delay image in your CT scan, that will outline the ureters and the bladder, and you can see the obstruction and the narrowing, or even infiltration of the lesion, or ureteric injury or rupture due to that lesion. So I will say just add more time to your CT rather than IVP. Unfortunately, we're not doing IVP anymore.
Okay, sir. Thank you. So next question, Dr. Amin. What is the next step after labeling intermittent or partial testicular torsion? Any guidelines for a follow-up? Asked by Rabia Salman.
I think it's more likely to refer the patient back to pediatric surgeon to let him decide the frequencies and other things. But I think like if it's an intermittent or partial testicular torsion, there is high chances of recurrence. So I think like it needs to be fixed rather than waiting for a complete torsion. So I think like it would be better to like direct it with the findings to the pediatric surgeon to make the final diagnosis what he wants.
Okay, sir. Right. So with this, we conclude our question and answer session for today's webinar. I'll be just sharing a brief slide for our upcoming session. Okay, so don't forget to join us on our last webinar scheduled on 1st of February for an exciting talk on career pathways, scheduled at 6:30 p.m. Pakistan Standard Time. Dr. Salman from Texas and Dr. Azika from the United Kingdom will be joining us to explore some career pathways in an interactive session. So kindly prepare your relevant questions so we can make this session very interactive for our audience. So with that, I would like to thank our speakers, Dr. Danish Barakzai, Dr. Mohammad Amin, and Dr. Kumail Khanwala for enlightening us with their experience regarding pediatric abdominal imaging. Thank you all for joining us and making our 4th webinar broadcast a massive success. Lastly, but never the least, thank you for the huge number of attendees without whose support this series would not have been possible. So inshallah, see you all next week. Thank you and goodbye, everybody.